My deepest apologies to Dr. Abraham for not introducing and seeing the, yes, backside of the page I was supposed to read. So I'm going to do it retrospectively and let you all know that she is a nephrologist. She's also the professor of medicine and at the University of Utah School of Medicine, and she began her undergrad and medical training in India. She then went to the United Kingdom and then came here to Utah to complete her master's in public health, and then went on to finish her internal medicine residency at the University of Utah School of Medicine, and then continued on for her nephrology fellowship. She is the clinical chief for the Division of Nephrology and also the medical director for the home dialysis program and the acute dialysis program at the University Hospital. So thank you, and sorry for that beyond, yeah. All right, so we are going to move on to our second nephrology, and I'm actually going to introduce him probably appropriately. So there you go. Please welcome Dr. Sammons. He is also sponsored by the National Kidney Foundation of Utah and Idaho. He is a nephrologist and assistant professor of medicine at the University of Utah School of Medicine. He completed his undergrad training at Cornell University, completed medical school training at Columbia University of Physicians and Surgeons, and then moved to Utah, where he completed his residency in internal medicine at the University of Utah, followed by his fellowship in nephrology in 2025. Steve joined the University of Utah as faculty in the Department of Medicine, Division of Nephrology and Hypertension, also in 2025, where he is the clinical director of the Polycystic Kidney Disease Clinic. Please welcome Dr. Steve Sammons.
All right, hello everyone, and thank you for the introduction. Can you all hear me okay? Okay, make a sign or something if that becomes not the case. So you all are in luck for having a second nephrology talk in a row. And I'm happy to follow Dr. Abraham, as I was one of her fellows until just recently. So again, my name is Steve Sammons. I'm a nephrologist at the University of Utah, and I'm the clinical director of the University of Utah PKD Clinic. And so I'm going to be talking about PKD, particularly autosomal dominant polycystic kidney disease. These are my objectives, so I hope this talk will help you all understand the clinical features, diagnosis of ADPKD, understand what we do for prognostication for ADPKD, and then also understand what treatments and management strategies we have for managing both the renal as well as extrarenal manifestations of ADPKD, as long as acknowledging the limits that exist to those treatments. I also hope that this will help people feel comfortable in knowing when to refer a patient with known or suspected cystic disease or ADPKD to nephrology care. My outline, I think, is redundant because I added in the objective, so I'm going to jump right into pathophysiology. So just really briefly, the two proteins that are shown here on the bottom left in blue and red are polycystin-1 and polycystin-2. These are the protein products of the PKD1 and the PKD2 genes. So these two proteins are membrane-based proteins or transmembrane proteins that form complexes with each other. And the complexes that they form, this polycystin complex or set of complexes, localizes to the primary cilia, which is the structure that is on the surface of most cells. And the kidney tubules are no different. They have these primary cilia, and the polycystins appear to play a major role in keeping those kidney tubules stable in that tubular form. So they're involved in a lot of different signaling within the cells and the tubular cells. And this is a schematic of many different signaling pathways that have been simplified, and in models with PKD, certain signaling pathways are upregulated and they're shown in blue, while other signaling pathways are downregulated, shown in yellow. As you can see, there's a lot going on in here, and the end result of this is that these nice tubule cells end up losing that differentiation and turning into a cystic phenotype, where there is promotion of cell proliferation, fluid secretion, and eventually leading to formation and then growths of cysts. This is a table that shows all the different known or suspected genes involved with PKD, but really the vast majority of cases, about 95% of cases, are due to mutations in either PKD1 primarily, or to a slightly lower degree, PKD2. And those are the genes that code for those polycystin proteins. But as you can imagine, there's a lot of regulatory components in the signaling pathways that these are involved in. And so there's also a whole set of minor PKD alleles that are outlined here, this 5%. And each of these has their own slightly different phenotype for the most part. But this is a more or less complete list to date. As far as epidemiology, ADPKD is the most prevalent monogenic kidney disease associated with kidney failure. There seems to be no major racial, ethnic, or geographic variation in ADPKD prevalence, and the asterisk there is that there's actually a small group in Taiwan of a special PKD2 variant, but other than that, really this affects everyone across the world at a similar prevalence. And ADPKD in the US and Europe accounts for about 5% of people really receiving kidney replacement therapy, so either transplant or dialysis. It's also the fourth leading cause of end-stage kidney disease after diabetes, hypertension, and glomerular nephritis. So really the most common causes you could think of things that cause kidney damage, PKD comes in right after them for fourth place. How common is it? The estimates vary a little bit based on the population studied and the methodology used, so whether or not you consider a genetic diagnosis or an imaging diagnosis, but by and large, the rough bottom line is somewhere between 0.5 to 1 people per 1,000 seems to be the prevalence, and again, that's across most populations. And if you think about that in terms of Utah, our population's about 3.5 million. That would be an estimated 3,500 patients with PKD, ADPKD in Utah, and then of course, a lot of you all are serving people throughout the Mountain West, so that population expands. Diagnosis of ADPKD depends a little bit on whether or not there's a known family history, and that's really the pretest probability is going to be different if there is known family history, but by and large, it's based on imaging. And for diagnosis, we recommend ultrasound as the initial screening test because it's a good enough tool to see cysts, to count cysts, to get a good idea of the distribution, but it's also quick, it's inexpensive, and it's readily available. Based on the number of cysts and the age of the patient, we actually have these nice criteria that have been laid out to either rule in or rule out ADPKD. And again, this is for people who have a positive family history. So I have a couple examples. If someone comes in, they're a 35-year-old man, they have a known family history, and let's say members of their family who have this have had genetic testing, we know it's PKD1. Performing a kidney ultrasound, if you see a total of 7 cysts, if you look on the top right table there, knowing this person's age, they're in that 30 to 39 category, and they have well over the 3 cysts, that's the cutoff for ruling in PKD. And there's really not that much added information actually knowing the genotype in this case, because the positive predictive value based on this table is 100%. So we can feel very confident that this person in this scenario has ADPKD. In another scenario, let's say there's a 46-year-old woman. She's got a known family history of ADPKD. The genotype itself isn't known, but it's been clinically diagnosed. And she has an ultrasound that shows a single cyst. And this is a very common situation. Someone has a family history, they get imaging for some reason, and there's 1 or 2 renal cysts. And of course, the question is do they actually have PKD, or are these just acquired kidney cysts that are common with age? And using the bottom table, you can actually see that she is below the cutoff of at least 2 cysts. So she has a very high negative predictive value of about 100%. So you could feel fairly confident in this case saying you don't have ADPKD, even if you didn't pursue genetic testing. Now, in some cases, as you can imagine, I use pretty clear-cut cases, but the ultrasound imaging can be equivocal, it can be borderline. There's a number of other options to use. So one is you can use a different type of imaging. MRI has better resolution, particularly of small cysts, so it can give a little bit of a better answer in people who are right on the borderline. You can, of course, do genetic testing and see if any of those known pathogenic variants are identified, and if you find one of those, then it's pretty clear that someone has the disease. And then you can also offer serial imaging, so let's say someone isn't interested in genetic testing, clinically they're stable. If you just image them every couple of years, and a rough recommendation is once every 5 years do a similar screen and just see if the number of cysts or the size of the cysts are changing at all. Now, the diagnosis is a little more murky in people who don't have a known family history, and this is not an uncommon issue either. About 20% of ADPKD cases seem to be from de novo mutations, so about 1 in 5 people. And then, of course, people might not, or family members might have PKD, but it's not diagnosed, or maybe people don't know their family medical history. Either the case, imaging still remains the primary tool of diagnosis. But in this case, genetic testing tends to be a little more helpful. And I'm not going to go through this whole algorithm because it kind of ties us all in circles, but essentially, if there's a very clear-cut multiple cysts and bilateral kidneys, including features like liver cysts, which are very common in ADPKD, that tends to point towards a diagnosis. And if it's obvious, it can be really obvious, and you can feel comfortable making a clinical diagnosis based on imaging. But if there's any kind of question, if there's an atypical presentation, let's say there's only a few cysts, there's no liver cysts, someone is older and they have preserved kidney function, genetic testing still remains a viable option that can provide a more definitive diagnosis. And then you could re-image every 5 years if there's still some uncertainty. So in patients who have these very typical presentations, especially if they have family history, genetic testing isn't always necessary, but it can really help in some of these special circumstances to make a diagnosis much more certain. And then even if you know the diagnosis and it's obvious clinically, genetic testing still has the potential for a lot of value. And really it can tell you about prognosis. So the prognosis of ADPKD does depend on the underlying genotype. And for those with a PKD1 pathologic variant, the median age of end-stage kidney disease or kidney failure happens in kind of the mid to late 50s. Compared to PKD2, which was that smaller portion of the total prevalence of ADPKD, PKD2 is more of a mild phenotype typically, and kidney failure tends to happen in the late 70s. Now, to make things more complicated, within PKD1, there are truncating and non-truncating variants, so the actual type of variant or mutation that's underlying the change in the protein does lead to a different phenotype. And this truncating variant, if there's an early stop codon, this is kind of the worst prognosis, and this tends to drive that median down into the 50s for all comers with PKD1. If you have a non-truncating variant, which is a smaller portion of that population, it's a slightly more favorable outcome, and these folks tend to have kidney failure in their mid-60s. The minor alleles, just very briefly, and these are pretty rare even within PKD, but they all have their own characteristic phenotype. By and large, most of them are moderate or low risk of actually having kidney failure, and some of the ones like GNAB and IFT140 have a very low risk. Most people don't actually develop kidney failure. They just might have some mild CKD and a few cysts. Unfortunately, this one NEC8, again, very rare variant, but if this is present and there's a pathologic variant, it's associated with a very rapid onset polycystic phenotype and actually leads to kidney failure, usually in childhood, unfortunately. Okay, I'm next going to talk about what we know about the natural history of ADPKD, and particularly how we know those things, and I'll go through some of the studies that have established this. So kind of the foundational study from 2006 was this CRISP study that looked at a population of about 240 patients with ADPKD. They were on the younger side, less than 50, and had normal kidney function at baseline, so their GFR was at least 70. This wasn't an interventional study, but what this study did is serial MRI to assess kidney volume, cyst volume, and then they estimated GFR, actually measured GFR throughout the study so they can track how kidney function and cyst size and kidney size progressed. On average, the mean annual increase in total kidney volume was about 63 milliliters, which, to put this in context, typical healthy adult kidneys are 150 milliliters each for 300 milliliters total kidney volume. The kidney volume increase directly correlated with the cyst volume increase, which we kind of take for granted at this point, but basically the reason kidneys are getting better in ADPKD is that the cysts are getting larger. It's not some other enlargement of the healthy kidney tissue. And the total kidney volume increase correlated with GFR decline. Also, the rate of GFR decline was dependent on the baseline total kidney volume. So larger kidneys led to faster decline in GFR. Some of the conclusions that were drawn for this is that the growth in total kidney volume appears to come from enlargement of existing cysts rather than production of new cysts. So new cysts can develop, but by and large, most of the cysts that someone with ADPKD has, they had when they were born, and they just slowly develop in size throughout their lifetime. Cyst enlargement also appears to be continuous and appears to proceed at a fairly steady rate that's specific for each patient, which is really valuable information because it means you can measure this kind of once early on and understand or predict what's going to happen in the future for each patient. And then larger kidneys at any given age predict a faster growth in total kidney volume and a faster decline in GFR. Because the study came out in 2006, there wasn't quite as much genetic testing, but the majority of people, or a little over half, did have genetic testing. And as expected, PKD1 variants were associated with larger kidneys, more rapid growth, and faster decline in GFR, which wasn't terribly surprising, but does correlate well with what we've known about those different genotypes. Now, this is a figure from a study that came out in 2015 from this group at Mayo, using a cohort of ADPKD participants at Mayo, as well as the CRISP cohort from a decade earlier. They put together this Mayo imaging classification, which lays out 5 different risk categories, or 5 different categories of people with ADPKD based on their age and their height-adjusted total kidney volume. Now, height-adjusted total kidney volume is important because height is a big factor of kidney volume even in healthy individuals. So someone who's 6'3" versus 5'3" are going to have different sized kidneys, so we need to normalize against that. But these categories are useful because, as you can see on the right, each category has kind of a characteristic GFR decline over time. So it's helpful to make predictions, and you can tell who is in what category even at a very young age. So even in, someone's in their early 20s, their GFR is completely normal. If you can put them in a category and you anticipate they stay in that category, you can make predictions about what's going to happen in the future and decide who therapy might be appropriate for. This is just a graphical abstract of a study that kind of revalidated this with some more recent data, looking at a group of about 600 participants. And this Mayo imaging classification is not perfect, and there definitely is some overlap, particularly between adjacent groups. But over the course of this study, and there was a mean follow-up of about 5 years, 82% of people maintained their category. So the vast majority of people stay in that Mayo imaging classification risk score. An important thing to note is that this Mayo imaging classification is only validated for people with typical ADPKD, and that means people who have bilateral diffuse cysts that are pretty similar on both sides, as shown in kind of the upper 2 figures. Sometimes we'll see folks who have unilateral disease or segmental disease, and any kind of atypical presentation like that, because it distorts the shape of the kidneys. It's not valid to use the Mayo imaging classification to make or it's not as accurate to use that classification. Now, the Mayo imaging classification is not the only scoring system or prognostic system out there, and so I'm going to talk briefly about this other system called ProPKD. This was developed a year after the Mayo group had published their results in 2016 and used a 1,300-person cohort looking at different factors that influence the progression of PKD in this group. And they found that 4 different factors had pretty significant impact on prognosis, and that was just being male. So men tend to have faster development of cysts and faster enlargement of cysts than females. Hypertension before the age of 35. So invariably, most people with ADPKD will develop hypertension, but if they develop it earlier, that's usually a bad prognostic sign. And then the first urologic event, so whether this is a cyst rupture, cyst infection, stone, any kind of urologic event, particularly early on, is also a bad prognostic factor. And as you can see, this study also includes the genetic testing. So based on the type of mutation, if this person has had genetic testing, you get either 0 points if it's the PKD2 mutation, or 2 versus 4 points if you have the non-truncating versus truncating PKD1. These 2 scores can be used together, and they have their own kind of niche, and really this depends on what you need to complete the scoring system. So the Mayo imaging classification, you do need imaging for this, and MRI is the preferred modality. You can calculate this with CT and even ultrasound, but MRI is what the initial cohort was validated with and just has better resolution and better spatial resolution, and so MRI is preferred. So ideally, the individuals will need to be able to do an MRI for this. ProPKD also requires genetic testing, which the Mayo imaging classification does not. So if someone is not interested in genetic testing, you wouldn't be able to actually get that ProPKD score value. And then there's some limitations in younger people with ProPKD. As you can imagine, 2 of those factors depended on something happening before age 35. So if you have a 25-year-old in front of you, you don't know if over the next 10 years they're going to develop hypertension or have a urologic event, and so it tends to underestimate risk in younger people. There's also some cases, this is a graph that shows the different risk scores kind of overlaid on each other. And there's a lot of cases where, for example, people who are Mayo 1C or higher, who are intermediate or high risk, a fair amount of them were actually labeled as low risk based on ProPKD. And so the scoring systems don't necessarily always agree with each other, but the bottom line is, they're both helpful. They both have been validated under different circumstances, and if you can use one or both of them, that tends to be helpful. Particularly for folks who are in an intermediate risk, if you can use the second scoring system to push you towards or against actually intervening with a particular medication, that can be helpful. Just some brief notes on imaging. I kind of went over this already, but MRI is preferred, but CT or ultrasound can be used depending on what's available. The total kidney volume measurements, by and large, most centers, including the University of Utah, we use the ellipsoid equation. So you just assume the kidney is a perfect ellipsoid. You get depth, length, height measurements, do some math, and you get the volume. There's another method called the stereology method, where there's actually computationally you can figure out the exact volume based on little changes in the shape of the kidney and the cyst. But overall, these correlate very well with each other. So this is a study that looked at CRISP and Mayo data sets and correlated imaging volume calculations using those 2 methods, and the R-squared value was over 0.95 in all these studies. So we feel pretty comfortable using the ellipsoid equation, and it tends to be a lot more straightforward. This is a figure I borrowed from the KDIGO, which is one of our international guideline organizations, that just shows the holistic approach to prognostication. And the 2 schema that I talked about, the MIC score and the ProPKD score, are part of this, but really they're a part of the puzzle. And knowing how someone's GFR has been changing, what's been going on in their family history, how other people in their family responded with a similar genotype can be very helpful. And then there's a lot of investigational factors or variables that are under study. Everything in this figure that's purple is something that the effect is proposed but not yet proven. So the hope is that, as this field develops, we'll have a lot more tools to say, hey, we expect this is going to happen in so many years. Okay, moving on to management. So I'm going to start with blood pressure, and I've alluded to the fact that high blood pressure is very common in this population. So most people with ADPKD at some point in their life will develop hypertension. Largely we've been treating it with the same goals and same goal blood pressure as anyone with chronic kidney disease. But in 2014, this study came out called the HALT-PKD trial that gave us a slightly different target. So you may see this being used in certain folks with PKD. This was a 2x2 trial published in the New England Journal. It randomized people based on standard versus rigorous blood pressure control. And standard at that time was 120 to 130 for systolic. Rigorous blood pressure control was 95 to 110. So it was a pretty low blood pressure. And then there was also this randomization between a dual RAS inhibitor, so an ACE inhibitor plus an ARB, versus just an ACE inhibitor and placebo. The subjects here, so it was over 400 folks or participants in the trial. They were less than 50. They had normal kidney function at baseline, and they had to have high blood pressure, and they excluded folks with diabetes or really high albuminuria. Compared to the standard blood pressure control, rigorous blood pressure control was associated with a slower growth in that total kidney volume, and it wasn't a major difference, but it was a significant difference in this population. There was also a greater reduction in LV mass index. So outside of the kidney, there were some benefits of some cardiovascular outcomes. And then albuminuria was better in the rigorous blood pressure group. Unfortunately, GFR, which is really what we care about and patients care about, did not have a significant difference in this study. And there have been some post hoc analyses of this population, and it still seems like there's no GFR difference even further in the future. As expected, people were more dizzy, they were more lightheaded when they had more rigorous blood pressure control, but there was no major difference in death, MACE, renal events, AKI, hyperkalemia. So by and large, it seemed to have been safe and tolerated in this group. And then that other randomization arm of the ACE versus ACE plus ARB, that didn't really pan out to anything at the time, and so we don't recommend dual RAS inhibitor. There are basically no differences in those outcomes. All in all, for blood pressure in people with ADPKD, if a patient is younger than 50, they have mild CKD, so CKD 1 or 2, and they're hypertensive, we do recommend hitting that rigorous blood pressure control target. And even though the GFR difference wasn't there, the fact that there was a signal with total kidney volume, but more importantly, albuminuria was better and some cardiac indexes were better. This is still at least a 1D recommendation from KDIGO. But for anyone that wouldn't have been included in that trial, if someone's over 50 years of age, if they have more significant CKD, we target a pretty typical less than 120 systolic goal for blood pressure. Okay, so I'm going back to this figure that I showed earlier on that shows this web of signaling pathways in the tubular cells and people with PKD and all the things that are upregulated and downregulated. And this pathway here that ends in cyclic AMP expression is one pathway that tends to really be upregulated in people with ADPKD. And so early on, there was interest in targeting this pathway to see if this could be a place for intervention with drugs. And that V2 receptor, I know it's small font there, but that V2 receptor is the receptor that vasopressin or ADH binds to. So this is, we all know this for sodium and water regulation, of course. It's that same receptor, and Vaptans are this class of medication that can bind to and activate that receptor. So because of that, tolvaptan has been studied pretty broadly in ADPKD, and to date is the only medication that is really disease modifying that's approved for use. Our understanding of tolvaptan primarily comes from these 2 trials within the last 10 to 15 years. The Tempo 3-4 study, published in 2012, included a younger cohort, people less than 50 with normal kidney function at baseline. And then a few years later, Reprise came out that had a cohort with a slightly broader age inclusion criteria, as well as lower GFR. So they studied this in kind of older folks and people with more advanced CKD. These were both multi-center, double-blinded, randomized controlled trials. They both enrolled over 1,000 participants each, and they had slightly different time frames, but they were between 1 and 3 years. And both studies really showed a similar outcome, which is that tolvaptan was associated with a slower progression of total kidney volume and a slow decline in GFR compared to placebo. And it was about 1.3 mils per minute per year between the 2 trials. I have a couple graphical abstracts that just show the kind of revalidation of this. And so this is looking at older patients, so people over 55. And this is a meta-analysis that includes the folks that were in Reprise, as well as a lot of case reports, and really shows that even in people over 55, there still seems to be this GFR benefit. And the final number they came to, I think, was 1.66 mils per minute per year. This is another graphical abstract, just highlighting a study that was done on real-life data. So these were folks who were prescribed tolvaptan, and they retrospectively matched them to controls with ADPKD and found that tolvaptan did appear, even over long term, and I think the mean time of follow-up was 5 to 6 years in the study. Even over a long term, tolvaptan was still led to an improvement in GFR compared to placebo, or compared to not placebo, but people who are not taking tolvaptan. Interestingly, in this study, and again, this is not a randomized controlled trial, but the total kidney volume improved initially and then kind of tapered off. So the longer term data seems to show that the kidney volume in that 5+ years out might not be as important, but the GFR, which is really what we care about, kidney function, that improvement is still there. Right now, the recommendation is adults who have ADPKD with a GFR of at least 25 who are at risk for rapidly progressive disease should be offered treatment with tolvaptan. And this risk for rapidly progressive disease, this is what I had reviewed with the Mayo Imaging classification. If they're 1C or greater, pro-PKD if they have a score of 7 or greater and they're in the high risk category. And there's some other ways you can kind of interpret data, based on their genotype or their historical rate of GFR decline. But however you do it, if they're at risk for rapid progression and they meet these criteria, you should at least discuss tolvaptan with folks with ADPKD. Now, tolvaptan is not a perfect medication. It is certainly not benign, and the feared complication is a drug-induced liver injury, which occurs in about 5% of people treated with tolvaptan. Most of the cases occur pretty early on in treatment, usually within the first 18 months, and it typically resolves with holding tolvaptan. So it seems to be self-limiting as long as you remove the affected or the agent that's causing it. But recurrence is pretty common, so you can re-challenge folks with tolvaptan, but most of the time the DILI comes back. There has been so far one case of liver failure that actually led to a liver transplant. This was a case reported in Japan a few years ago. There haven't been any other cases, but in large part that's due to the caution that has been exerted around tolvaptan use, and it's only available through a REMS program in the US. So for actually prescribing tolvaptan, when you do this through the REMS program, you need liver function tests at baseline, weekly for the first month, monthly for the first 1.5 years, and then it's every 3 months, lifelong, as long as the person is on therapy. So it's quite a bit of lab burden, at least up front, and then it does taper off over time. And the KDIGO guidelines have a nice set of flowcharts that help you adjust the dose throughout treatment and then manage any changes in the LFTs that you may have, and I just have those pictured here. Altogether, tolvaptan isn't a perfect medication. At the moment, it's the one agent we know that's really disease modifying and actually changes GFR in people with ADPKD. And I didn't mention this directly, but a lot of those studies that have looked at it, even though their primary outcomes were GFR, total kidney volume, people treated with tolvaptan actually had fewer acute pain events, fewer stones, and so there's probably some other benefits too. The studies just weren't really powered for those in particular. That being said, there are certainly harms associated with tolvaptan. Because it's binding the V2 receptor and inhibiting that, it's essentially a nephrogenic diabetes insipidus. And so people pee a lot, they need to drink a lot, people can become hypernatremic, really easily dehydrated, especially when you step up the dose of medication. And then, of course, the drug-associated liver injury is always a concern. Some uncertainties with tolvaptan, and this may sound surprising, but we haven't had a study that was powered in a way to definitively show it actually delays onset of kidney failure. So we know reliably in different populations it slows the GFR progression, and the assumption is that's going to delay kidney failure, but we can't really say based on how the trials have been designed that that's certain. And then because this has only been available for about a decade, the long-term data just aren't there on long-term use of tolvaptan, what's the tolerability, what's the effect of modulating AVP levels on this agent for a long time. Hypernatremia, I mentioned, but hyperuricemia is something else tolvaptan can cause. And so I have at least one patient I know of who had a history of gout, very well controlled, put him on tolvaptan, and then suddenly had a gout flare. And it was probably the tolvaptan. So being very mindful of where people's uric acid is, and you can still treat through with anti-uricemic medications, but something to be aware of if using this. And then tolvaptan, people on tolvaptan should have a sick day plan, kind of like someone on chronic steroids, where if something happens, if they have a GI illness, if they're doing an activity where they don't have access to free water for a while, having a plan in place where they can pause or dose reduce is important to avoid an episode of dehydration. Going back to this figure that shows the web of signaling pathways in the tubular cell, we've been talking about tolvaptan because it inhibits this V2 receptor, and if you think about the physiology here, vasopressin or ADH activates this receptor. So anything that stops vasopressin or stops ADH from being active could theoretically have a benefit, and this is largely where the recommendation to drink a lot of water comes from in people with ADPKD. Until recently, we didn't really have any trial data that showed whether or not this is beneficial, but there was this study that came out in, I think, 2023. It was a multi-center study in Australia that asked this question, can giving extra water actually be as good as tolvaptan? So this study included adults up to age 67 who had a wide range of kidney function. They enrolled down to GFR of 30, and they had kind of a broad group of people of different Mayo classifications. They included Mayo 1B, as well as those more advanced 1C, 1D, and 1E groups. And then anyone who couldn't drink a lot of water, couldn't do an MRI, or had something like diabetes, glomerulonephritis, some other reason for kidney failure, they were excluded. The group A control, it's not that they told people not to drink water, but the usual practice was continued. They saw their nephrologist, they told them drink water 2 to 3 liters a day, and that was that. The intervention was actually much more targeted on keeping the urine osmolality low. And the way they did this is they actually did baseline measurements of 24-hour osmolar clearance by each patient to see how many osmoles they're consuming a day. They found their average. They figured out how much water they would need to excrete to keep that urine osmolality at or below that level. And then they included insensible losses and gave them a prescription for water. And it wasn't just they gave them a prescription and sent them out the door. They had dietitians. They had folks that would come to the patient's house, I believe, and check in on them. They gave patients urinalyses so they can do specific gravity at home and make sure they're hitting these parameters. So it was a very involved study to actually get them to hit this target of drinking enough water. Unfortunately, it was a negative trial. So there was no difference in height-adjusted total kidney volume, which was their primary endpoint, and then all of the secondary endpoints were also negative, no difference in GFR, no difference in blood pressure, albuminuria, or kidney pain scale. So besides being a negative trial, they actually had a lot of difficulty keeping patients in that high prescribed water outcome. It turns out it's really difficult to drink that much water. Some folks did have hyponatremia, but it wasn't really a safety issue. It was readily resolvable, and there weren't any major safety events between the two groups. But and this is just from the paper itself, prescribing water intake, it's difficult to maintain over the long term and appears to be insufficient for suppressing ADH and kidney cyst growth in most patients. So where does this all land? We still recommend 2 to 3 liters of water, because certainly volume depletion, not drinking a lot of water, anything that's going to trigger high levels of ADH likely play a concerning role or could accelerate cyst growth, but we don't have great evidence that going above and beyond this regular 2 to 3 liters has any benefit. Okay, I'm going to go over some past and some future directions, and this is by no means comprehensive. There are certainly other agents out there that I haven't listed, but mTOR inhibitors, which are readily used in immunosuppression and in the transplant realm, that mTOR pathway is actually one of the pathways that gets upregulated in the tubular cells in people with PKD. Unfortunately, we've already done studies on mTOR inhibitors. They don't seem to show any improvement in total kidney volume, and they actually were associated with faster eGFR decline and more infections as expected, because they're immunosuppression medication. So that is kind of a dead end at the moment. Statins, interestingly, have some mixed data. There was a small randomized controlled trial recently in adults that showed no difference in outcomes, but there were some problems with the way the study ended out. There's a lot of loss to follow-up. It was open label. And there's another small randomized controlled trial in children that actually showed improvement in height-adjusted total kidney volume in the treatment group with statin therapy. Somatostatin analogs, kind of similar story to mTORs. There's some theoretical benefit. There were some trials that actually showed a marginal improvement in total kidney volume, but GFR didn't change, and there were a lot of adverse effects, so these have largely been abandoned. And then metformin, another kind of generic medication that's readily available. There's one small randomized controlled trial that actually shows positive results, so a better or less large total kidney volume at 12 months. At least at that study, there's no change in GFR, but there's a trial called the IMPEDE PKD trial, which is currently recruiting. We're not a center, and I actually don't know where the nearest center is, but very excited to hear about that, because if something like metformin turns out to be beneficial, that's, we all use metformin readily. It's very cheap, very inexpensive, so that would be a great improvement for the field. Beyond medications, there are some other interventions or lifestyle interventions that are being used or investigated, and one I wanted to talk about are ketogenic diets, because this is something that's been pretty popular within the PKD realm. Cells in people with PKD, these tubular cells, kind of like how in cancer there's this Warburg effect where they're metabolically dependent on glucose, these tubular cells seem to have a similar property where they're more dependent on glucose, and in preclinical models there seems to be some benefit to cyst growth inducing a state of ketosis. This has been studied in kind of a lot of small trials, and there's only one randomized controlled trial to date that I've dug up, and I have a figure here from it showing that compared to a control diet, a ketogenic diet made the height-adjusted total kidney volume slightly less, but it did not reach significance. Interestingly, the height-adjusted total liver volume, which I haven't really been talking about because it's not usually a surrogate that nephrologists are monitoring closely, that was actually significantly better. So, that is kind of still remains to be seen what the clinical importance of this is. And to be fair, this was a very short, relatively small trial. I think it was only 3 months total. So, whether this is going to apply in all people with ADPKD are a select group or anyone still remains to be seen. But the risks associated with a ketogenic diet, because it's been a popular diet in the general population for a while, are relatively well known. And depending on the person, this is something I'm supportive of, but don't recommend specifically. As long as we're watching lipid panels, watching out for cholesterol, in certain people who are really motivated, this is, has some evidence behind it. Okay. Another future direction that I'm particularly excited about is related to this group of microRNAs called microRNA 17. These are regulatory mRNAs that seem to be upregulated in people with ADPKD, and inhibition of the microRNAs raises the dose of the residual polycystin protein complex. In mouse models, and this is a figure from a PKD mouse model, treatment with microRNA 17 inhibitors actually makes the kidneys much smaller, and as you can see, that comes primarily from smaller cysts. And this agent is called farabursen currently. That's been used in humans, and so far we only, could you go back a slide? Sorry. So far we only have phase 1 and 2 trial that so far shows some early promising clinical data. The total height-adjusted total kidney volume was actually much better in folks in a dose-dependent manner treated with farabursen, but so far this is a small phase 1/2 trial that was really powered for safety events, and so we don't know for sure what the use of this could be. Now, we're actually going to be a center for this study, so I'm very excited about that, and hopefully in sometime over the next few months we'll begin enrolling patients, and we'll maybe learn more about this agent. Other general considerations for management of ADPKD, and this is in the context of general CKD management. SGLT2 inhibitors, we all love them. They're miracle drugs. They work for everything. Unfortunately, because they induce an osmotic diuresis, there's a theoretical risk in people with ADPKD. That same reason for, we were talking about water, increased vasopressin activity in someone who's on an agent with an osmotic diuresis could exacerbate cyst growth, and there's some concerning findings from animal models. All of the major SGLT2 trials in CKD excluded people with PKD. So we have no idea from EMPA-Kidney, all these trials, whether or not people with PKD would actually benefit or if they would come to harm. And there's actually, the University of Colorado is in the process of going through this trial where they're going to study empagliflozin in people with ADPKD. So this is another thing that we might have some more information for just in the next couple of years. And then this is, I'm sure not many people are using these agents, but these hypoxia-inducible factor inhibitors or HIF inhibitors also have a theoretical risk in people with ADPKD. Human data is pretty limited, and so we recommend against using them except for people who are already on dialysis. In whole, from a dietary perspective, if you look through this chart, and I'm not going to go through it in detail, but most of the stuff here are things that we recommend to the general population. So there's not really too many specific dietary recommendations that we would give to someone with PKD versus just CKD. Drink plenty of water, reduce sodium intake to less than 2 grams, protein intake, this is the exact amount we recommend for the general population with or without kidney disease, and then moderate calorie intake, fat intake, high fiber, general healthy diet. Okay, I have a little over 10 minutes, so I'm going to jump into some of the renal-specific complications outside of just GFR decline of ADPKD. And the first one is cyst hemorrhage. So these cysts, as they're enlarging, as they're torsioning and moving around and being pressed in the body, they can rupture and they can bleed. This typically presents with sudden onset flank pain, and it's usually pretty well localized. It may or may not present with hematuria. So these cysts can communicate with the collecting system, but they don't always. And so someone who has sudden onset flank pain and they don't have hematuria, they could still have a cyst hemorrhage. Most cyst hemorrhages resolve spontaneously, so usually in 2 to 7 days, within a week. symptoms start to taper off and improve. And it's rare that we actually need to intervene on these, except in cases of severe hemorrhage. So if someone is showing signs of hemorrhagic shock, if you get imaging to work up their pain and there's an extension into the RP space, something that's not going to tamponade off on its own, or if the cyst communicates with the collecting system and we're seeing urinary obstruction from clotting. Those are all cases where we actually do need to intervene. Any hematuria that persists longer than 7 days, or hematuria where it's the first episode in someone older than 50, these are indications for imaging to exclude malignancy. And that's very important because folks can have short, self-limited hematuria associated with cysts rupturing or being torsed, but if it lasts longer than a week, you really need to be thinking about malignancy. And while there doesn't appear to be any causal indication between ADPKD and renal cell carcinoma, people who have ADPKD, their presentation is much different and can be harder to diagnose and easier to miss a diagnosis of malignancy such as renal cell carcinoma. So these folks tend to present with fever, fatigue, weight loss, much more commonly than the general population. Cyst infections are another complication related to these cysts. So, and this can happen from an ascending infection, from a UTI that can be seeded separately. There's a set of diagnostic criteria that I have listed out here. You pick 2 from any of these 2 categories, but by and large, this presents like a kind of a complicated UTI. So people with ADPKD can have simple cystitis, and that's treated very similarly. But if they have systemic symptoms, if they have fever, if they have vague abdominal pain associated with some urinalysis changes, and then if they have increased inflammatory markers, all of that are reasons to suspect a cyst infection. And really, if you're uncertain, imaging can be very helpful, and sometimes we'll even need to do guided aspiration of cyst fluid if there's a cyst that has streaking around it and looks like it's infected. Knowing whether or not someone has a cyst infection is important because the treatment is actually very different. Acute simple cystitis might have a very short course of antibiotics, but the cysts have difficulty getting good levels of antibiotics into that cyst tissue, and so certain antibiotics need to be used like fluoroquinolones or trimethoprim sulfamethoxazole, and longer durations, often 4 to 6 weeks. So this is kind of like treating prostatitis is the analogy. People with ADPKD have a much higher risk of kidney stones. So even in unaffected family members, the risk, it's almost twice the chance that people will have kidney stones. Uric acid tends to be a little more common in this population compared to the general population, but calcium-based stones are still, the champion there. They're the most common. There really is no consensus about any type of screening for people with ADPKD looking at kidney stones. Even though this is common, there hasn't been anything that shows that some screening program has been beneficial. And we generally manage people with ADPKD and stones the same as we do people with kidney stones for any other reason. So nothing really special there. If they have multiple stone events, doing a metabolic workup, doing alkalinization of the urine if appropriate, anything like that is still applicable in these folks. Kidney pain is something that can show up either as acute or chronic pain. And again, acute pain could be related to cyst rupture, hemorrhage, expansion. It could be a stone, and then people with ADPKD can have anything that normally causes abdominal pain. So oftentimes if there's new acute pain, like anyone else, we would think about imaging that includes the kidneys. Chronic pain, though, is unfortunately very common, and it can be a major burden on patients. And the degree of pain doesn't always correlate well with the kidney volume. So sometimes people have very large kidneys and they feel generally great, maybe a little bit of bloating, but other folks will have relatively small kidneys for someone with PKD and can have a lot or a very high burden of chronic pain. The mechanisms of pain, there's a lot of things that can probably contribute and probably do contribute. Any kind of traction on the renal pedicle, distension of the capsule, because that's really what's innervated inside or on the outside of the kidney. And then if there's a cyst rupture, infection, any nociceptive stimulation in the surrounding area can also contribute to pain. This figure here is from the recent KDIGO guidelines and just shows a kind of stepped approach to addressing pain. And what I'd say is, once you go kind of beyond the first or the second rung here, this is probably a patient that should be being seen by a multidisciplinary group that includes nephrology, urology, maybe hepatology if the liver cysts have been bothersome, and potentially interventional radiology and pain management. Ideally, we start with minimally invasive interventions, Tylenol, compresses, whirlpool, meditation, and then progressively more invasive interventions can be considered with more and more refractory pain. Kind of the middle of the chart there, the most invasive things we could do are nephrectomy, but of course we'd want to reserve that to people who have really intractable pain that's not being resolved with anything else. Okay, a quick note on extrarenal complications. So people with ADPKD are at higher risk of intracranial aneurysms, or ICAs. The risk in the general population is about 3%, and in people with ADPKD, it's about 13%, so it's quite a big jump. Now, if someone has ADPKD and they have a family history of an intracranial aneurysm or a subarachnoid hemorrhage, that jumps up to 17%. So it's getting close to 1 in 5 people could have an intracranial aneurysm. Because of that, we do recommend at least discussing screening in people with ADPKD, especially if they have a reasonable life expectancy and they'd be willing and eligible for treatment if an aneurysm was found. And there are some particular indications, but what I'd like to point out is on the bottom here, even if someone doesn't have family history, if they're not an airline pilot or any of these high risk or have any of these high risk occupations, if they desire screening for peace of mind or for family planning or something, that's still appropriate and that's supported by guidelines and should be covered. As far as the actual screening done, we prefer MR, and this can be done without contrast. It uses this time of flight method, but CT angiography is also appropriate, and depending on the center, you could do either. If screening is negative, there's limited data on how often to rescreen, but people are still at risk even if they've had a negative screen. So in general, we suggest between every 5 to 10 years. So I think I'm hopefully right on time here. I'm going to talk just briefly about the PKD clinic, and then I have about 4.5 minutes left for any questions. So as I hope I've described today, ADPKD is a unique disease within nephrology, and it requires specialized and often multidisciplinary care depending on what manifestations it has. And in addition to just clinical care, people with ADPKD should be given opportunities to participate in trials and local registries, especially because this is really an evolving field and there's a lot of new treatments that can be difficult to connect patients with or as investigational agents. My hope is that this historic pessimism around ADPKD, because we don't really have many great disease-modifying therapies, will be eventually replaced by understanding what options we do have, which aren't nothing, but also with the promise of future therapies and some of these investigational agents. Anyone with PKD, whether it's autosomal dominant, which I know that's really all I've talked about, but even autosomal recessive polycystic kidney disease, other cystic kidney diseases, or other genetic kidney diseases, anyone we're happy to see at the University of Utah at our PKD clinic. And even people with mild, stable disease may benefit by access to trials, family planning resources, and disease-specific registry. We also, take care of a lot of people on tolvaptan, and so we're set up for the REMS testing and have a good protocol with that, and I know that can be kind of a nuisance for a lot of people to manage. And then people who have undergone genetic testing and either have negative or difficult to interpret testing, imaging that might be atypical, or they have comorbid diseases that are also contributing to drop in kidney function. They're especially important people to be seen by nephrologists. I just want to put a plug in for an organization that we partner with called the PKD Free Alliance. So this is a group that offers grants to people who have PKD and are interested in undergoing pre-implantation genetic testing and IVF, they can pretty greatly offset the cost, and really the cost is still unfortunately a major burden. But this is a really successful therapy, and if people have PKD, they know they have this, they've had genetic testing, and them and their partner are looking to start a family, being able to reassure themselves that they're not passing it on for people if that's their wish can be really empowering. So this is a great organization that we hope to continue partnering with for a long time. And I think that's all I have. Thank you very much.
It's been a number of years ago, but I had a patient with a family history of PKD, and we wanted to do an ultrasound, but his insurance said that even if we did the test, even if it was negative, they would increase his insurance rates. I'm wondering if that's still a problem.
Yeah, very interesting. So the question is basically if, at what point does insurance not increase the insurance rates if this is in the family? Now that we have really well validated criteria, this isn't something I've specifically experienced, so I can't speak from experience, but we have very well validated criteria where you can confidently say someone does not have ADPKD. And because it's dominant, if they don't have it, they're also not going to pass it on. And so I think that's a situation where, and I don't know if this was just because the evidence base wasn't quite there at the time, but if someone has a negative ultrasound and particularly negative genetic testing, you could feel pretty confident saying, look, they don't have this condition, they're not going to develop this condition.
So I get a lot of ultrasounds on the liver, and occasionally I see cysts. The question is, how many cysts, when do I need to start worrying about PKD and maybe investigating that a little more thoroughly? How many cysts should I mean, a lot of people have an incidental cyst or two, but how many should I look at?
Yeah, absolutely. And so the question being, you see an incidental cyst, at what point do you get worried? By and large, as people age, we all develop cysts in our kidneys. So seeing one or two cysts is generally not concerning. The older someone, the younger...
This was cyst in the liver, though.
Oh, cyst in the liver. Okay. So there are some of those minor alleles that I listed in one of the earlier slides. They tend to cause more of a polycystic liver disease, and there is an autosomal dominant polycystic liver disease, which is its own etiology. And these people have liver cysts, and they don't have kidney cysts, or they have very few. And those folks, for the most part, do not have kidney failure or really any kidney disease. So I think if you're seeing exclusively liver cysts, that's a situation where it would be totally appropriate to think about genetic testing in someone like that, maybe sending them to human genetics for further evaluation or sending them to hepatology. But it's not, if they don't have kidney cysts or they have very few, particularly if they're in their 30s, 40s, or older, it's very unlikely that they have ADPKD.
Are you using SGLT2 inhibitors in your clinic currently?
So right now, based on that theoretical risk from osmotic diuresis and SGLT2 inhibitors, we're not using them routinely in people with ADPKD. Certainly most other types of CKD, we try to get people on SGLT2 inhibitors if they tolerate it. My hope is that there's this study at the University of Colorado looking into this, and as long as there's reassuring safety information from that study, I think that could change sometime in the next couple of years. I believe it's a single-year trial, but I'm not entirely sure. So to answer your question, no, but I'm optimistic that we might have a better answer soon.
Okay, well, that took care of question number 2, which was, have you seen creatinine increases in the SGLT2?
Yeah, and there's at least one person that came to me with PKD with really poorly controlled diabetes on an SGLT2, and that same hemodynamic effect is certainly there, but we ended up taking them off of it in that situation.
You've probably seen studies of increased kidney volume and increased cyst size in some of the animal models. Mm-hmm. Is that of concern, or are we still waiting to see what happens in Colorado?
Oh, within SGLT2 inhibitors?
Yes.
Yeah, I mean, I'm certainly concerned about that being a driver. I mean, we'll see. I guess you never know until the data is there. But at this point, it's not something I prescribe in people with ADPKD.
I have a specific patient I'd probably like to discuss with you later if you'd
Come
have
find
a
me.
moment.
All right.
Thank you.
Thank you.